Anna, for your wonderful presentation. So, okay. So, as Joanna said, my name is Andrés García BAYCE from Uruguay. I will talk about torch. I have no conflict of interest, and first I will acknowledge the collaboration of these two nice colleagues from Brazil, because I'm going to show some cases that took place there. So what is TORCH? We are all familiar in pediatrics with this acronym. It consists of infection in neonates caused by the TORCH infective agents that cross the placenta during pregnancy. These agents are toxoplasmosis, O for other, including syphilis, rubella, cytomegalovirus, and herpes. Sometimes you may find this other acronym like TORCH or STORCH, because some people include the S for syphilis at the end. We won't do that. Normally we refer to it as TORCH, and we may add this C for Zika virus, because we are commenting on that one, which is not very usual in every part of the world. So going to our first pathology, we are commenting on this 34 weeks gestation, where we performed a prenatal ultrasound, finding calcifications of the brain of the fetus. In transvaginal ultrasound, we found evidence of cortical atrophy, microcephaly, and periventricular calcifications, as you can see here. We performed an fetal MRI where we encountered this diffuse cortical atrophy, enlargement of the ventricular system, and also microcephaly with this occipital bump here protruding, and also some degree of cerebellar atrophy. So very fast, a cytomegalovirus diagnosis was made with blood tests. As you know, this is the most common congenital infection, with up to 2.4% of live births. Even if antibodies are identified in up to 60% of all pregnant women, only 2.5% have primary infection during pregnancy. And of these, only 30% of these cases result in fetal infection. We may have some clinical symptoms, but it's good to know that 90% of babies are asymptomatic. So we also may find a delayed global growth of the baby with a thick placenta, like in this case, and intestinal hyperechogenicity of the fetus, and also oligohydramnios and ascites. In postnatal images, we may find, besides these intracranial calcifications I already mentioned, some subependymal cysts, as in this case, in this chorothalamic groove. You may know and may see it's not a simple cyst. These are normally complex cysts with septae and looking like multiple cysts. This is another case with complex cyst where we also find perithalamic vessel calcifications. This is called lenticulostriate vasculopathy. And this very nice work, the authors tell us that there are many causes for this lenticulostriate vasculopathy. You may find this quite usually even in normal babies, but you should know many of these TORCH infections greatly grow the incidence of lenticulostriate vasculopathy. So you may always suspect a TORCH infection when you find this. In CT, you will find again microcephaly, this coarse or not so coarse periventricular calcifications, ventriculomegaly. And in magnetic resonance, you may find in some cases migration abnormalities and lesions of the white matter, and even in some cases delayed myelination. But the most usual thing is this ventriculomegaly with enlargement of the ventricular system and the subarachnoid space because of cortical atrophy. Those are all severe cases. In abdominal ultrasound, again, we may have hepatomegaly. In postnatal ultrasound, hepatic calcifications that may be conspicuous, coarse calcifications, and nephromegaly with increased renal echogenicity. This is other thing we may find. If we perform an X-ray of the limbs, we may find changes in the metaphysis due to metaphysitis. This is a pattern called celery stalk metaphysis, but it's not specific for cytomegalovirus. We also find it, of course, in syphilis. Well, going to our pathology number 2, we have a case of a 27-year-old woman with no history of congenital anomalies. In his 12th week of pregnancy, he had fever, maculopapular rash, and arthralgia with a negative torch blood tests, normal exams in the 12th and 21st week of gestation, and in the 32nd week, we found a microcephaly. You can see it here. Severe microcephaly. In the ultrasound, we found a microcephaly with cortical atrophy and some coarse calcifications with absolutely normal measurements of the rest of the body of the fetus. So what do we find in MRI in this case? Fetal MRI finds this ventricular dilatation, cortical atrophy, microcephaly, marked microcephaly, this occipital prominence here, and this redundant skin folds. This is very characteristic. You may notice almost normal measurements and appearance of the rest of the body. It's limited to the brain. So this is quite characteristic of the Zika virus. This Zika congenital syndrome includes these findings: microcephaly, atrophy, ventriculomegaly, and these calcifications. In many cases, it has this severe form, which adds an excess skin to the scalp with these skin folds and this frontonasal rectification. If you see at the profile of the fetus, you may find that also in ultrasound, you have this rectification. They may have altered neurological symptoms as this. In some cases, you may find dysgenesis of the corpus callosum and also eye deformities, but not so usual. So what is this Zika virus? It's an arbovirus transmitted by this arthropod, the Aedes aegypti mosquito. In concrete, it is a flavivirus. A flavivirus transmits all of these entities. We are commenting on 2 of them. These arboviruses, and this mosquito is involved in all these entities: the dengue fever, and the Zika virus syndrome, and the chikungunya virus. Here we see the distribution of the mosquito, and it is in these regions that we have most of the cases. In concrete, in my region, we had a big growth of cases in 2016 with almost a pandemic in some regions of Brazil. Well, what do we find? The mother, when she's infected, will have a fever of acute onset like this mother, with a maculopapular rash, arthralgia, or conjunctivitis, but that's only in some cases. 80% of cases are asymptomatic, so you will know. But when they are affected, like in this case, we have a baby with a head circumference of 29 centimeters, that is microcephalia, because 32 centimeters is the limit for microcephalia. In postnatal ultrasound, we may find these calcifications. These are quite characteristic. Those are cortical, subcortical calcification, punctate calcifications that you may only find in Zika virus infection, like in this case. Again, in CT, microcephaly, dilatation of the ventricular system, and gross calcification. You can see here in the reconstruction the occipital prominence and the rectifications of this angle. Well, in what do we have in MRI? Well, we may have these migration disorders, like pachygyria in this case, smoothness of the cortical surface, or in this other case, this numerous small gyri, that is polymicrogyria. You can see here this rectification, the deformation of the cranius, of the skull, and also the microcephaly, and also this skin, redundant skin here. Less frequent findings are microphthalmia, even joint contractures, like in this case, or cerebellar atrophy. Let's move on to our pathology number 3. This is another case, 33 weeks of gestation, large dilatation of posterior horn of the lateral ventricle, with all these cortical and caudothalamic foci of hyperechogenicity interpreted as calcifications, and also here the corpus callosum dysgenesis. We found also parenchymal cavities that may be interpreted maybe as abscesses, because toxoplasmosis was quickly detected in blood tests. We also found fetal ascites and hepatomegaly, and this intestinal hyperechogenicity we also found in cytomegalovirus before. As for MRI, we also find the ventricular dilatation, and these cystic areas that may be interpreted as the same cysts we saw on ultrasound. We may also find in T2 these hypointense foci that correspond to calcifications. Small ascites and fetal ascites, and then here hepatomegaly. Another important findings may be a greatly thickened placenta. So we commented on all those images in the brain, this progressive hydrocephalus, so you don't have an atrophy. What you have is a real hydrocephalus, progressive growing hydrocephalus, calcifications, in some cases cataract, and even small parenchymal abscesses. In ultrasound also the thick placenta, the intestinal hypergenicity, ascites, in some cases pericardial effusion, and hepatomegaly, as in this case. You see, the foci of hyperechogenicity in the brain, in the postnatal, may be seen clearly as here, but in some cases they are not that clear and they're not that bright. You may see them also in CT with no microcephaly, but multiple calcifications, and in this case, moderate dilatation that will progress of the ventricular system. So, moving to our pathology number 4, this is a boy of 22 days. He was born 7 weeks of gestation, and because of hypertension and oligodrenius, on the labor day, the mother had fever, maculopapular rash, and arthralgia. Neonatal screening for infection was positive. They made antibiotics, but he had fever, irritability, and septic shock. So we had a positive result for chikungunya virus. This is the other virus we mentioned when we mentioned the mosquito, the chikungunya virus. This may cause inflammation. When you perform an ultrasound after the acute infection, you may see, as in this case, periventricular leukomalacia, cystic areas of leukomalacia in the brain. Also in this case, we saw this hyperintensity in both lateral ventricles is a bleeding, a classical subependymal bleeding. And in CT, we had periventricular and peritrigonal hypodensities. Also very tiny and subtle hyperdensities here that may be interpreted as small areas of bleeding. And in MRI, T1 hypointensities periventricular and peritrigonal here at the right, and in T1 hyperintensities. So this is our virus, the chikungunya virus, is also transmitted by the same mosquitoes. There are two genres of Aedes mosquitoes that transmitted it, mostly Aedes aegypti, and its mother's viremic state during the week before delivery is the major risk factor for vertical transmission. So the mother gets infected in the last part of the pregnancy and transmits to the baby. So this, we have an onset of symptoms after birth, always with fever, irritability, rash, and edema. with these characteristic phases. So moving on to the next and last pathology, we have a boy, 1 month, irritability and pain during lip manipulation of the baby. It was a normal delivery with a mother with prenatal consultations, multiple consultations. We had a VDRL positive blood test for syphilis. So the mother was correctly treated and the father received no treatment. And the neonate unfortunately underwent no further investigation. We performed an X-ray and we have some of the classical signs like this rarefaction in the metaphysis of both tibias and femurs. Is a metaphysitis we may find very frequently in syphilis. We have also signs of periostitis in the long bones of the upper limbs. And also in this case, a pathological fracture here that may be a differential diagnosis with child abuse. So, as is usual, it's a normal brain ultrasound, but you may also find lenticular-striate vasculopathy, the one we mentioned before. It's more frequent in syphilis than in normal children. So it is also a vertically transmitted infection caused by Treponema pallidum, as you know. In the early form, it presents in the first 3 months of life with rash, lymphadenopathies, pathosplenomegaly, rhinitis, and failure to thrive. And some infants only progress to meningitis with seizures and also osteochondritis and developmental delay. So, but you should know clinical symptoms may not appear for several weeks after birth. When they appear, the involvement of the bone is very frequent. It's usually multiple and symmetrical, so X-ray is a very good exam. And periosteitis and cortical demineralizations in the area of Can we cut that? Okay. Are very common. You can also have the classical Parrot's pseudoparalysis, that is the pseudoparalysis due to the pain of the child when you manipulate his or her limbs. So I mentioned some classical infections are quite well known by everyone working with children, and some other not so classic. To make it more useful, I made a short scheme that may help someone finding some conflicting findings, and I made this table to differentiate some of the things that may be confusing. Can we differentiate between this cytomegalovirus, toxoplasmosis, and Zika virus findings? Because have other things to help us. But in this case, it may be confusing, these causes. As for the cerebral classifications, in cytomegalovirus, they may be cortical and periventricular. They may be punctate, of course. In toxoplasmosis, they are cortical and nodular, and so they may be bigger, not so hyperechogenic in ultrasound as you've seen. And in Zika, they may be cortico-subcortical. If you happen to see those pointy punctate foci of calcification in ultrasound, you may say this may be Zika. As for the microcephaly, in cytomegalovirus may have microcephaly. In toxoplasmosis, it's much less frequent. And Zika virus, we almost always, in these severe cases, have a microcephaly with this occipital prominence, this frontonasal rectification I showed you, and these redundant skin folds in the back of the head. Neuronal migration anomalies, you may find some in cytomegalovirus. You will almost never find them in toxoplasmosis, and you may find that also in Zika virus infection. As for ventricular dilatation, you've seen ventricular dilatation in all those pathologies I showed you, but the reality is in toxoplasmosis, you have a real dilatation that is a progressive hydrocephalus that will continue. But in cytomegalovirus or Zika, it's more of a compensatory dilatation because you have a cortical atrophy, so it's not a real hydrocephalus. Continuing with the cerebellum, in cytomegalovirus, there can be areas of hypoplasia or degeneration. Toxoplasmosis too, it may affect the cerebellum, and Zika virus is mostly preserved in more cases and then supratentorial. In the abdomen, you may find cytomegalovirus and toxohepatomegaly and increasing intestinal echogenicity, ascites, all signs of inflammation, acute inflammation. But in Zika, it's very notorious, you have no changes. So normally, the rest of the body is normal. So it's very specific for the brain, all the affectation of the Zika virus. You may find in cytomegalovirus and toxoplasmosis a thickened placenta, but normally in Zika it's normal, again. This characteristic profile, which is normal in cytomegalovirus and toxo, but maybe have this rectification, frontonasal rectification in Zika virus infection. And finally, the retardation of the intrauterine growth may be present in cytomegalovirus, that is a global retardation of the growth, not present in toxo, and less frequent, as I told you, in Zika virus infection. Well, I hope this has been useful, maybe useful in the future for your daily practice. Thank you very much for your attention.
Thank you for staying. I'd now like to call the last speaker, Professor Donald Frush, who's well known to ISR as the co-chair of the Quality and Safety Committee and is the chairman of Image Gently and I think a co-chairman at Duke University. Thank you, Don. He's going to talk on abdominal infections.
Thank you, Tim. As the slides are